for everyone to join before we start today's webinar. I'll make a start. So for those of you that are new to the e-prescribing masterclasses, these are our monthly webinars where NHS organisations share their learning and experiences of digital transformation to help support others. And this platform really aims to break down silo working and create a community where others can learn from innovation and lessons learned from optimising digital systems. Today we've got 3 speakers. So we have a pharmacy terminology update, then we'll have a session around the impact of hospital and electronic prescribing systems and conversation about medicines, and finally there will be a discussion around the electronic prescribing and learning lab. On the GoTo platform there is a question and answer box which I'd encourage you all to put your questions in, and there'll be, if there's time at the end of the presentations, we'll have a few questions where we'll give these to our presenter, and if not, they will be answered after the webinar itself. And as part of attending today's webinar, a certificate of attendance will be emailed out to you, as well as a recording. And if there's any topic that you'd like to present on, please do get in touch with Sarah, whose email will be available at the end of the presentation. And it's really great to get, a variety of speakers who can share their learning and digital innovation. So I'd like to first hand over to Paul Wright, who is part of the pharmacy terminology team at NHS England, to give us a pharmacy terminology update. Over to you, Paul.
Thanks, Amna. Can you hear me okay?
Yes, I can hear you.
Thank you. Hi, good afternoon, everyone. Yes, my name is Paul Wright. I work in pharmacy terminology in NHS England. I've come on these masterclasses over previous months to give updates with regards to terminology updates, particularly in relation to DMD and SNOMED CT. I just have one quick update for the audience today, just one slide, but it was an update from something that I presented on at the October 2024 masterclass in relation to a SNOMED international proposal. If you could just go on to the next slide, please, Sarah. So there is just this one slide of information today. And this is following up on the proposal that SNOMED International have regarding their increasing of the description length limits for their fully specified names and synonym descriptions, which are currently at a character length of 255 and are planned to go up to the maximum character length in their file, which is 4096. When I presented on this back in October, SNOMED were running a consultation which ran until the end of 24, so the 31st of December, for stakeholders to submit their feedback around impacts, questions and concerns around this. So obviously that deadline of the end of the year has passed. At that point, the UK had submitted 35 responses into SNOMED International, which is the biggest level of engagement from any of SNOMED International's members, and there are around 50 of them now. So it was really good to see the level of engagement and feedback into SNOMED from or where they have to consume it through interoperability means, and also their concerns around impacts to user interfaces. So SNOMED have received all that feedback and have been looking through it, and at the moment they've just published some new information which is available on DELIN, and I've shared the article name in full so people can get to that. At the moment, SNOMED are planning to implement this change in January 2026, so obviously just under a year away. That would come into effect in the UK April 2026 release, because we publish international edition content twice yearly, both in April and October. At the moment, that's a planned implementation date, and SNOMED are still writing up the results from the consultation that they've had and confirming timeframes, and that's due to be published around the end of Q1 this year. So I will again share information as that becomes more concrete. If any UK stakeholders do require more time than that, then SNOMED International would like to hear from them, and there is emails at the bottom as to how to get in touch with them. We as NHS England and the National Release Centre would appreciate being copied into any feedback that goes to SNOMED International, so we have visibility of that. The 35 respondents to the survey have all been made aware of this as well, so directly had that feedback that this is just another opportunity to let people know about this work that's going on. In terms of impacts that had concerns raised about it, yes, it will impact back-end systems that do ingest this information, and you know, if there are systems out there that are ingesting content from the medicinal product hierarchy of SNOMED International edition, then they will be impacted. In terms of user interfaces, it all depends on how implementers implement content in their user interface. So this would impact synonym descriptions, it would impact preferred term descriptions, it would obviously impact the fully specified name descriptions. However, there is a guidance from the NHS SNOMED CT standard SKY 0034, in which the guidance is not, they shouldn't use FSNs in user interfaces to record content in patient records. However, that doesn't mean that doesn't happen, so that could potentially be an impact. And there's also implementations where if you hover over certain terms, then FSNs will be displayed. So not exactly an impact that may not be seen. So there's some information on here. I will pop my email in the chat if anyone wants to reach out to me to discuss this any further. I'm happy to talk to anyone, and as I said, I'll keep the group updated with any more information as it comes through from SNOMED International. That's the end of my presentation, and I'll hand back over to Amna.
Thanks, Paul. So like Paul said, if anyone wants to reach out to Paul, his email is in the chat now. And I'm really pleased to welcome our next speaker, Angela Bergin. I've known Angela for a number of years now, and Angela is the NIHR Clinical Doctoral Research Fellow and a registered independent pharmacist prescriber with over 25 years of clinical pharmacy practice experience. Specialising in clinical informatics and digital health transformation, Angela is dedicated to enhancing the delivery of personalised care in the digital age. Her research focuses on the impact of EPMA and EPR on communication around medicines with patients and the healthcare team. Angela is also a passionate advocate for embedding pharmacy practice research and patient and public involvement in healthcare improvement. I'm delighted that Angela is here to talk to us today about the impact of hospital electronic prescribing systems on conversations about medicines, a realist review of the literature. And if you do have any questions for Angela, please do put them in the Q&A box, which you'll find on screen. And if there's time at the end of Angela's presentation, we'll be able to ask them directly to Angela. I'm going to hand over to you now, Angela.
Sandra, thank you so much for that lovely introduction, and thanks for the opportunity to come here today and to present some of the output from my research and my PhD. Yeah, for those that don't know me, my name is Angela, and I've got 6 months left of my PhD. And in terms of what I'll be talking to you about today, there are 3 work packages to the PhD, and you'll see a bit more about that. But today, I'm giving you, I suppose, the outputs and the recommendations that have come from the literature review that I've done as part of that work. So I think it's probably important to say at this point that I suppose what follows is not the absolute final recommendations for the research in its entirety, but it's certainly a very good version of that. It's like a summary or a synthesis of the literature and summarising what we already know, and the recommendations have come from that. So there will be more from me in the next 6 to 12 months, because I'll be looking to supplement this work with observations of practice, to refine and improve and bring that a bit more up to date. But for today, yeah, I'll talk just about the literature review. So to do that, I'm just going to ground us a bit first in the research and where it came from, and we're going to time travel back in time a little bit. So this is a dear friend and colleague of mine from a previous job I had, and he's beautifully demonstrating, probably from either the late 80s or the 90s, what pharmacy and healthcare with medicines, or care with medicines, looked like. And for those of us, if we can remember back then, or if this was our experience, the prescription was on a paper chart in a folder, and that was kept at the end of the patient's bed. And any time we had to do any work with medicines, any of us, it involved going to the bedside to pick up the chart and to have that conversation. And then if we fast forward, sort of 10, 15 years later, from this picture, we can see that the systems have been digitalized, and those paper prescription charts and paper notes were transferred or moved, our tools were moved onto the computer, and instantly we can see, and certainly as a practitioner at the time, really felt the impact of that and how that had changed practice for me personally. But supporting trainees and others working with it noticed that it changed them quite significantly for them as well. And so, yeah, it sort of triggered this curiosity and this fascination, and I've become really obsessed, I suppose, with how our behaviours and practices are evolving in response to the technology. And I think one of the things that's really struck me over the years is that, you know, digital systems have been put in to really help us work together more collaboratively, to really try and help deliver this personalised care by being able to share information. And when we look at the Topol review and other reports, you know, Topol said that these systems should give us the gift of time to nurture that patient-practitioner relationship. You know, and that really has been the intention. You know, they're here to try and help bring these efficiencies. And when we look at the shared care agenda and personalised care agenda, you know, the idea is that that's what they're there to do. But I think what we've noticed is that it can detract and take us away from the patient bedside just by shifting and changing the tool. And actually, because of that, we're not speaking to patients as much. They're not as involved in conversations about medicines and their care in the way that they may once have been. And that's really at odds, I think, with what we're trying to do in terms of personalised care. So that's where this all started for me, and it's been a passion for the last 15 years or so. And in terms of the scope of this research, you know, there are lots and lots of benefits of these digital systems, and I feel like I always have to say I'm not a naysayer. I've worked in clinical informatics for over 10 years now as a specialty, and, you know, really do recognise the benefits that they bring. They're well documented, and we all know and see those in practice. But I think it's fair to say that, you know, with those benefits, these systems always bring unintended consequences. It all comes as part of the package with the technologies, and they do bring inefficiencies, they bring problems and potentially safety issues too. And often we don't really know what we're getting until we plug it in. And actually, you know, I think it's one of those where I think we're probably not very good at really trying to understand those unintended consequences, because I think by looking at those and examining them, it will help us make best use of the technology. And I think, interestingly, when I was putting this presentation together, there was some articles flagged up from December 2000. So this was published in The Sun, but also The Guardian. So it was hot news at the time, but the headline was, "Internet, there may just be a passing fad as millions give it up. You know, we're waiting for the revolution." And what was interesting reading those articles, you know, was that the idea that the internet was promising to revolutionise our lives, and the feeling was generally that it hadn't. And quotes from the articles are, "The promise that it would simplify our lives didn't seem anywhere close to being realised." And also, this was quite interesting, "Email seems to be adding to and not solving the problem of information overload." And I just thought, gosh, how fascinating that, you know, 25 years ago, the problems that were identified back then, we still see and feel now. Not much has changed in terms of that, and I suppose the way we're expecting it to work hasn't materialised, and that's not changed. But interestingly also, it wasn't a passing fad. Millions didn't give it up, and it's absolutely here to stay. And I think when we look at Lord Darcy's recent report at the end of last year as well, he shares this view of the NHS remaining in the foothills of digital transformation. And he really highlighted the need for us to sort of really understand, why and how we use the technology the way we do, so that we can really try and fully realise the benefits of systems by changing and improving how we work with them. And I think just as a final I suppose, stop before we move on to the actual research. This is a quote I came across fairly recently that really resonated. So if we take time to notice what just happened, we learn how the system operates. And without reflection, we go blindly on our way, creating more unintended consequences and failing to achieve anything useful. And that really struck me, actually, and it made me really think about the work we do with digital in healthcare, because as somebody that's worked in healthcare for 25 years on the receiving end of this, and certainly as somebody that's worked doing the implementing, we do put systems in, time after time, and we don't really stop to look back on what's happening with the ones that are already in. And the problems that do arise sometimes then compound and become more of an issue as time goes on, and people just seem to carry on with the behaviours and such like. So yeah, it just really made me think, gosh, yeah, it made me feel that the work that this research is about, really is needed, I suppose. So the aim of this research is to understand, to explain and describe the consequences of replacing those paper charts with electronic prescribing systems. And obviously, because I'm a pharmacist, the focus of it was around medicines and that idea of communication about medicines between patients, clinicians, and the wider healthcare team. And I think, it's this thing of trying to understand why those consequences occur, who they occur for, and in what context do they occur. So, as I say, there were 3 work packages to my research. The first work package is a literature review, and I'm using an approach called the realist approach, which I'll talk a little bit more about in a minute. But the output from the literature review was, or has been, to create some initial theory from the literature that describes what helps or hinders this conversation about medicines when we use technology at the bedside. So that's what you'll hear about today. The second work package I'm coming near the end of now, but the idea is that I'm collecting data from 2 case study sites, the 2 hospital sites that have the same system. I've been doing observations and interviews on a medical ward at each site and a surgical ward at each site. So all of that data I'll be using to test and refine the theory that has come out of the literature review, so that I'll end up with what we know in theory from the literature, what we know from practice, to then bring that all together and create some final recommendations in work package 3. And the aim is to share those recommendations with participants of the research and get some feedback from them to see whether the recommendations are valid and whether they, can be translated and used in clinical practice. But as I say, for the purposes of today, I'll just be talking about the output from the literature review. And as I say, I'm using a method called the realist approach. So this is quite different to doing a systematic literature review, because when we do systematic literature reviews, we're I suppose, summarising or synthesising the evidence base to work out or to know what works and what doesn't. In a realist approach, it's all about understanding or using the literature to work out how complex interventions work, or how they might unfold when we put interventions in place. And what it does is it really helps us to really drill down and understand the causation of why things work and why they don't. So what does work for people in what circumstances, and why does that work for them? And I think as a method, it really it recognises that when we put interventions in, so things like electronic prescribing systems, as is this example, when we put these interventions in, we're putting them into a sort of a wider system that's already set up. There are already current cultures there, there's history, there's lots of working practice already embedded, and social structures going on around that piece of kit or that intervention. So for somebody like myself, I felt that that approach or this method really fitted beautifully with this. And you know, realism or the realist approach is becoming more used in healthcare now because of the way it really drills down and examines and looks into things. So you may start to come across this more often. And the way that we present or share the information, or the way we focus what we're looking for, we talk about contexts, mechanisms and outcomes. So the sort of data that we're looking for is the circumstances or the context that trigger or modify somebody's behaviour. So context or circumstances are usually things that we can see or describe in the environment. That is really looking at what works, what doesn't, and who for. This approach also then enables us to really drill down and understand mechanisms, and these are explanations of what generates the outcomes. So these are often hidden, often inside people's heads, or in, I suppose, amongst people. So things that can be mechanisms are usually beliefs or interpretations. They can be processes like feedback mechanisms, or structures such as social class. So this is about how things happen. And then finally, we see the outcomes, and they can be either intended or unintended. And you can, and what we're looking for are patterns of outcomes when we put this certain context and mechanisms together. So yeah. So in terms of the results, I'm going to talk today mainly around pharmacists, and I think the data set for this has been so vast and covers doctors, nurses, I think prescribers. We've moved away from this term of doctors now, it's prescribers, which covers advanced practitioners, and obviously pharmacy technicians too. But I think for the purposes of today, to try and contain it, I'm going to focus a bit more, focus just on pharmacists and their work. And in terms of the results, as I say, the intervention or the electronic prescribing systems are in place, and I will be starting at the outcomes or the things that we've seen that have changed in response to the technology, because those are the things you know, that really interest me and started this research. So there have been 3 key outcomes of interest relevant to this area as consequences of using these EP systems in practice. And these were around patients and communication. So the first one is that we have had reduced communication with and involvement of patients in their care. The second outcome from the literature has been around workflow, and specifically around reduced professional presence on the ward. So that's been very much noticed with medics, but certainly the emphasis is more actually around pharmacists and the lack of their presence in ward areas, and technology has been attributed as a significant contributor to that. And then the third one is in and around the changes to pharmacists' day-to-day tasks and their roles. So they're the 3 main outcomes I'll be talking us through. And I think just something else to say at this point is that doing this work has really made me think differently about outcomes of system use. And I think we've all, or the majority of us, have been there on wards for implementing these systems. You know, we've seen firsthand that when we put these systems in, they have like an instant effect almost on people and their practice. You know, and that does occur in the moment in response to that changing tool and the use of the system. But I think what's become quite clear, and the way this work's made me think slightly differently, is that we do also have outcomes that occur later down the line. So as practice and as people adopt and adapt to the technology and adopt it, and practice starts to evolve over time, we end up with secondary outcomes, or outcomes that appear or become more apparent later on down the line. So the way this is presented is, you know, I'll talk about instant or almost immediate or primary outcomes, and then secondary outcomes, which occur a bit later. So the first, as I say, is around this patient communication. So we are seeing, and it is known now, that we spend less time with patients as a consequence of electronic prescribing systems. And actually, EPR as well is a contributor to this, because it also changes our conversations when we do speak to patients. So it changes the nature of the conversation, it changes the content and what we actually say, and patients have reported and staff that it actually changes the quality or reduces the quality of those conversations. And I think by default of that as a thing, you know, we have reduced incidental findings about patients, which can contribute or help with the care that we deliver, because we're not with them and they're not telling us those things, and we're not having those conversations like we did before. And then obviously as practice evolves, what people report over time is that, you know, we have reduced rapport with patients because we're not seeing them as much, and actually that relationship with patients is less or becomes poorer as a consequence too. And I think as a final note that's been quite interesting doing this work is recognising or seeing that actually you know, we tend to focus and go to the record more for information about patients, but actually the fact that they're not as involved in these conversations and they don't fuel or feed as much of what we put into notes, that patient narrative can also be lost or not present in the record too. So, you know, there's an impact there too. The second output is around staff workflow. So this idea of reduced professional presence on the ward for pharmacists specifically. So, you know, pharmacists have been described as not being there as much. And actually what has happened as a consequence of that is that there's a lot less opportunity for conversations with other healthcare professionals about medicines. But actually, again, we've seen that it has actually also changed the nature of the conversations that we're having with staff. And then again, as practice is evolving and pharmacists aren't on the ward as much, what's been noticed is that, you know, the longevity, or as time goes on, communication continues to change, and actually that working relationship with other healthcare professionals has also been affected. And there's now evidence to say that doctors are less likely to ask pharmacists questions about medicines because they're not easy to get a hold of. There are multiple steps, or they're trying to get a hold of pharmacists and they can't, so they tend to seek advice from others around them in the ward and in the vicinity. And nurses have also reported that these systems have negatively impacted communication with pharmacy staff. And then the third change is about change to tasks and roles. So this idea that, you know, these systems go in, and I think it's quite obvious to say that for pharmacists it has changed our day-to-day tasks, and examples of that have been about the fact that, you know, we're not having to mark charts anymore with a pen. That rework around the prescription to make it safe and able to order doesn't happen like it used to, but it does still happen. The nature of that work is very different now, and I'll talk a bit more about that later. But equally, when we think about the systems holding clinical decision support within them, or we build medication lists with pre-populated information around prescriptions and doses, you know, the computer is offering and providing a lot of that information. So actually we're not getting the medicine queries that we once did. And in addition to that, we're finding, and it's shown, that we are spending much more time on the computer. And whilst it can speed up lots of the work that we do, and that kind of benefit in terms of time gain is offset by the fact that we are having to spend more time inputting information and documenting on the systems. And in terms of what happens as time goes on and how things evolve, is we're seeing that there's actually a shift or a blurring in the lines of responsibility around medicine tasks. And certainly for pharmacy, there's evidence now to say that there's a real loss of direction with the work that we're supposed to be doing. What's our focus? What are our jobs? And now what do others do? And that will become a bit more clear as we go. There's been variations in practice and ultimately a change in role. So pharmacists talk a lot now about being not just medicines experts, but experts in the prescribing system. And whilst people like myself and most of us on the call are happy to take that as part of our identity and what we do, a lot of people haven't asked for that. And so I think some or most have embraced it, but you know, it wasn't something I think that was foreseen, but that's certainly become something that they now do. So those are three main outcomes that we'll be talking a bit more in detail about. So if we start off with the reduced communication with an involvement of patients, the way I'll present the rest of the information in and around this is I'll first of all talk about the contexts or the triggers, if you like, or what is it in the environment that contributes to this as an outcome. And then I'll then describe the mechanisms which will appear in this sort of paler area to the right. So interestingly, in terms of the data that we have and what we already know, the tools and technology have been obviously attributed to I suppose, contributing or causing these problems. And in terms of the specifics of that, people have said that if the tech is not available when we're doing the work with medicines, if it's not available near the bedside, that's a problem, and that doesn't help us have these conversations with patients. If the system enables or facilitates remote access, by, you know, just by that being a function that's available, that has been found to reduce our contact with patients. And finally, if the technology does not actively prompt patient involvement in that decision-making discussion or process, or if it doesn't enable patient self-management, which from my experience, I think the majority, if not all of them, don't, then that again can affect and contribute to this idea of reduced communication with patients and their involvement in medicines care. And the mechanisms and explanations as to why that might be the case are that, you know, these systems hold a lot more information and knowledge about patients that prior to being digitalized we didn't have, you know, and that was one of the promises and the benefits of having them, is that, you know, there's much more information in the systems, and that's great because it can really help us, inform our decisions, and really help deliver this kind of up-to-date clinical care. And so that seems to be a go-to in terms of information source. But actually the system then becomes considered as indispensable by staff in the consultation. And it actually plays a very active role. You know, it's not they talk about black box. It's not a box that's just, you know, with no effects or action. You know, it is part of, I suppose, the information sourcing. And in terms of the technology as well, you know, it has been described as being distracting. People have talked about it. You know, if it is there by the bedside, it can disrupt and interrupt the flow of the conversation. And actually nurses have described feeling hindered by the technology when they've had to take it to the bedside too. So yeah, in terms of explanations around the tools and technology, that's that. There are also things called organisational factors that can contribute to this. And by that, I mean the structures that organise our time, our space, our resource, what we do. It can include things like the culture and the training, and also organisational policies as well. So the context or the contextual factors that have been identified are things like if staff are not given appropriate training. So sorry. So if staff are not provided with appropriate training to really enable them to use the technology in an appropriate way as part of the consultation, that's been identified as a problem. And also this idea of the culture of the ward and the organisation and of individuals, if that doesn't support patient involvement as part of daily practice, then that can be a factor too. And I think it's one of those where, you know, it still exists, this hierarchy and perception that, you know, between patients and healthcare practitioners, that still does exist, unfortunately, in some places. It's been identified that the ward environment is quite important too when delivering or when trying to involve patients in their care. And busy, chaotic areas, that specifically areas like A&E, have been documented in the literature as not being conducive to a conversation. And I think also the other thing to think about are things like other procedures or policies within the organisation that can affect patient involvement. So if we think about things like having set administration times, for medicines or infection control policies where patients are tucked away, that can also contribute and impact whether or not we can get to the bedside and involve them in care. And then finally, and this has been an interesting one, the clinical context or the clinical condition also matters. So if your condition is surgical rather than medical, it is likely that less time will be spent talking to patients about their medicines. So that's been quite interesting, and that, you know, is all around this idea that the prescription is not the focus of the treatment. So if you're in a medical ward with a medical condition, you know, the focus of care is around the medicines, and you know, just by sheer consequence of that, you're more likely to interact and speak to patients about medicines. But on surgery, that's been recognised as not being as common. And other mechanisms or explanations, I suppose, as to why staff respond this way to their surroundings is that they just don't often feel confident, or they might not have the skills, or, you know, the organisation might not set up and support them to work and deliver shared care and shared decision making. And actually, you know, thinking about this environment and the culture around patient involvement, patients can feel worried about challenging healthcare staff. Sorry, I think, is this, I don't know if that is for me, but I can hear somebody. Okay. And then finally, you know, we kind of think about all of that, and, you know, one of the key factors is actually about the people involved. So, you know, we all come at this from very different backgrounds with very different ideas and beliefs and experience. So, you know, we need to think about and look at what these individual people bring to the space and how that can impact things. And some of the really interesting things that have come out of the literature is in around staff years service. That has been recognised as contributing to reduced communication with patients. And if staff members have low number of years service, then it's been documented that they may not speak to patients as much as people with longer years service. If staff don't feel secure or confident to allow patients to express their concerns, so that's a bit of a different kind of conversation, you know, and does require some support, training, and confidence to do that. So if staff don't feel able to do that, then it's an issue. And also this idea of staff and patients don't have defined roles in their care. And by that, I mean things like patients having a role in medicines administration, or staff understanding their role in the shared decision-making approach. And in terms of, you know, what that means, or why people respond the way they do, you know, staff can really struggle in terms of confidence, or, you know, they may not have the relevant knowledge or experience. And if we think about people who have been qualified for less number of years, you know, they may not feel confident having a conversation with somebody who's going through something very difficult. Or they might not feel able to explore that with them. We've found that pharmacists who have less years experience said that without that paper prescription chart, they didn't feel they had the skills or the ability, or they found it difficult without that as a focus to start a conversation and build rapport, whereas their colleagues who had been around for longer said that, you know, when they got the electronic chart, it didn't really impact the amount of time they spent with patients. They still, you know, saw the relevance of that conversation and made the effort to go. So it's just quite interesting that that experience does, you know, count for something, and we need to be aware of that. But there's not much more in the literature, if I'm honest, in and around the mechanisms around the people. The only other couple of things I could find were around this perception of pharmacists felt that, well, they perceived that there was an added layer of legal protection with the tech. So this idea that the medical record was the sole version of the truth, and that there was sometimes a mistrust, not a mistrust, I suppose, recognition that people don't always remember things. So patients might not remember stuff, and therefore, you know, their first port of call was always a written or the medical notes. And, you know, particularly because it's digital now, it's not like losing a piece of paper. So that was always the first place to go, you know, and then they might go and speak to the patient later. And there was also this thinking that because of the internet and access to technology, that patients, you know, a perception that patients are better informed with digital. The two has meant that the staff may not speak to patients as much. So that was that. So in terms of recommendations, you know, one of the quotes I came across was the goal of professional activity impinges on personal relationships with the patient, and that feels very true and pertinent for this particular thing. And I think the things we can do to really try and support and enable staff to go to the bedside and have these conversations, sit around the training of staff in terms of advanced communication skills and this idea of delivering patient-centered care through shared decision-making approaches, but equally providing staff with the appropriate kit that, you know, either prompts or enables in a way that's meaningful. And I think ultimately there's just definitely something about the culture of patient involvement, and, you know, giving patients or their carers the opportunity to contribute and to be more involved in those discussions about medicines, and help the staff to develop the ability to do that and do it proactively. And I think finally there was another point that came through from a paper from nursing actually around, you know, do we need to really just redefine what care means for the different professional groups when we're delivering care in this technology rich environment? And I thought that itself as a concept was quite interesting. So the second outcome was around this idea of workflow and reduced professional presence on the ward. And just as a reminder, this was about pharmacists not being on the ward and that affecting our communication processes and practices and our relationships with the wider healthcare team, and pharmacists not being asked or consulted as much, I suppose. So again, the tools and technology, there was a lot in the literature about this, and things that where the technology doesn't help us is if, you know, people or staff talked a lot about being poor availability of kits or the kit not working. They talked about the software of the kit not fitting with clinical workflow or practice. They talked about systems being slow, or about the Wi-Fi. So if the Wi-Fi drops out, you have to start again, and it's all problematic. And yeah, so this, you know, the Wi-Fi and it working properly is, you know, really important. And also this idea of there's often not sufficient time to use the technology in flow. So, I mean, I think surgical ward rounds are a good example of this in that they're quick. So the time it can sometimes take to do the tasks in the system around medicines, there's just not the time afforded for that, because it takes so much time to get through the clicking and what have you to action and get done what you need to get done. And again, this idea of the fact that, you know, if remote access is available, that is an enabler for people to not be there on the ward. And in terms of our organisational factors, you know, one of the things was really around this idea of the culture and climate for collaboration. And if that isn't great to start with, then it's very difficult when the tech goes in to grow or to nurture that. So yeah, so that was one of the things. And then what we find is that, you know, once the tech goes in, if practice isn't adapted or changed and space and time's not provided to support this collaborative work with other people around medicines, then that becomes, you know, that hinders our work in this way too. And again, we don't really know why at the moment, but clinical context, you know, whether you're on surgery or medicine, you know, there is a difference in terms of presence on the ward, in the literature anyway, presence on the ward, and, you know, pharmacists being less present on surgery compared to medicine. And in terms of why that is, I think the key thing is the fact that there's more information now available in the systems about patients, and this idea that we can actually access that and in theory don't have to be on the ward. And, you know, that is incredible. It's part of why these systems were put in place. As I say, you know, this idea of collaborative care, there's so many people to contribute to care, and we're all able to do that in one place. But I think what I hadn't really quite realised before until I started doing this work is that, you know, that's collaborative in one way, but actually what digital systems don't do is they don't support collaborative face-to-face work. And because of all these issues listed on the left there, you know, it's become quite clear to me now that the technology, it supports or enables more asynchronous approaches to work. And so we're, as that is the enabler there, and as a consequence of that, we're not in the room at the time that we need to be to be having those conversations when it matters. And the change in information flow is a huge part of that. And then, as I say, if we start to bring in the person and the individuals to this space, again, low number of years experience has contributed to this. The information needs of the recipient, so if somebody needs information that's complex, then you tend to find that they will go to the ward to find stuff out. But if it's not, if it's fairly what we term as standard information, then they may well just stay rummaging through the notes. And also there's something around the person and their digital literacy and the ability to navigate and find and extract information. That is part of this too. And why does that happen? I think one of the key things that's come through quite strongly actually is that there's this perception that when we document stuff in electronic patient records that we're contributing to care, and and on the surface ultimately I suppose we are, but that then becomes the contribution. And what seems to be happening is that when people are faced with less time and competing priorities, is that they can then that becomes how they contribute, rather than being on the ward and in the conversations to start with. Staff believe that they're being more efficient working in this way. And again, there's this layer of protection or reliability if we're faced with litigation that's driving this behaviour. And people are sort of identifying the action to go and speak to others. It's more appropriate for key situations, and recognising, that we need to use these tools to communicate information. If we need to, they're sort of reserving the conversation more for, if we need something that's much more complicated. So in terms of recommendations, again, it's about ensuring that staff have access to essential functioning and enabling kit, and that, we develop that space, or whether it's a kind of a meeting or a board round or something, or an office where people can come together to work collaboratively rather than just being on the ward and sitting by themselves. They need to be mixing with others and to work together in that way. And that, that can be formalised even just as touch points on the ward. And then I think finally, just to change to task and role, conscious of time now, so I'll just very quickly whiz through this. So as I say, the day-to-day has changed significantly for us, and that is, if the information about medicines isn't easy to find, to extract or enter, that's changed what we do. If it offers this additional resource in terms of clinical decision making, or the pre-filled order sets, if we can access it remotely, or if it's configured in a way that doesn't regard professional group work domains, that was quite an interesting thing, then that can be a real contributor to changing what we do. And I think one of the key things that came out of this was that if the emphasis of the work is more about the computer and the supply of medicines rather than the collaboration, then those tend to be the key drivers for this change in task and role. And a lot of it is around the fact that there's more information available now, and that we need more time to read it, to input it, to extract it. And I think ultimately what's happened is that it's changed the division of labour and who does what. So thinking about the fact that doctors might need to enter a diluent or an infusion time, or if the system forces them to do that as part of the prescribing process, if we don't acknowledge that new knowledge is needed, and if we don't help with that in some way, they end up taking on new roles. Pharmacists aren't thought to find that information. There becomes this sort of change and divvying up of the task starts to move, and I'm not sure we've really ever clocked that to any great extent before. And I think over time, and what's been noted is that that is shifting the power structure between the different staff groups around medicines. And ultimately, pharmacists are starting to feel a sense of loss of control around their work with medicines and feeling a bit more threatened as to, others being more in charge of that. And I think finally, just to say that, you know, this idea of low numbers of years service and also, you know, poor computing expertise, you know, they do also contribute to, you know, how we use the systems and how we do our work. So, yeah. So in terms of our task and role, I think it's important that we understand and define those professional boundaries around medicines and where things blur and overlap, and try and understand the impact of that on individuals and how we can evolve roles and support people to develop in those roles, you know, in a way that's helpful, and to try and, I suppose, help shift or change how the work is done, and what is it that we actually do that adds value and brings value to patient care. So in conclusion, a realist approach has hopefully, I certainly feel it's provided a useful insight into technology use in healthcare. It feels like that there's some really good theory there, or it's been put together in a way that really helps identify these contextual factors and also mechanisms as to, you know, what staff are faced with and how they respond and react to the technology in practice. And hopefully over the next 6 months I'll be able to add, because the stuff that's coming out of the observational data is utterly fascinating, and certainly adds to what I have presented today. So thank you very much for listening, and for listening through that. And I've realised a bit short of time now. Sorry.
No, it was really interesting to see all the work that you've done to date on this research, and it is really important to really understand, I guess, you know, how it impacts the way we work and do our roles using technology. So it was really interesting to see this, and it'd be great when you finish the work for you to come back and share the final outputs of this. And we do have time for one question, which I will share with you. So the question was, well, first, it was a fantastic talk and summary of the issues. Do you think we're at risk of losing the habit of involving patients in discussions as those staff with this already embedded into their practice progress to non-clinical roles or leave employment? And what can teams do to help keep this approach alive?
Yeah, it's an interesting one, isn't it? I think, so interestingly, there's been a paper that said that this idea of poor patient involvement is deeply ingrained in practice. And I think what technology has done is it's made that worse. I think it's very difficult. I think it would require a different skill set, and certainly not one that has been developed over the years with pharmacy. And you know, we spend a lot of time counselling, and I think the shared decision approach and the advanced communication stuff is, I think, now coming to the fore. And I know that people are being taught that, but there's certainly things that need to be taught to support and enable that. I think in terms of keeping it alive, it is fascinating. I don't know the answer to that yet.
Yeah.
There's lots of approaches, isn't there? It's interestingly, I was working with a pre-reg as part. This was about 2 or 3 years ago. Excellent clinically, due to sit the exam, and it was, we did the review, sat at the computer, and I said, "Oh, should we go and talk to the patient?" And it was like, "Well, what about?" So anyway, we did. And it was such, I was partly, you sort of stood there praying that like it's going to be a really useful interaction, and it was, because they always are. This is the thing, isn't it?
Yeah.
So I think it's only by, I suppose, leading by example, by role modeling, and we're trying to, I think it's difficult because one of the pushbacks from all of this has been, well, I don't have time to do that. My challenge to people has said, well, even if you could just try and do it with one person, start with one person a day and build up and work on that, then, hopefully we can start to, maybe practice morphs and become something else then. But yeah, I don't have the answers for that fully, I'm afraid, at the moment, but I'm very passionate about it and want to see the change. So yeah, hopefully soon we'll have more of an idea.
No, that's great, and thank you again, Angela, for sharing this work. It is really interesting, and like I said, we'd love to have you back when you finished the research itself. If there are any other questions, we'll send them to you, Angela, just in the interest of time today.
Sure.
And then we've got we were supposed to have my colleague John Gilliam join us, but he's also having some technical issues. So I'm just going to share with you the discussion area that he was going to talk to us about, which is around the electronic prescribing and learning lab. So the work is in its early stages currently, and what it is, it's aiming to draw upon the current evidence-based findings from ePRAISE around reported incident trends, provider case studies, and produce supporting materials to define what good looks like for hospitals in e-prescribing systems and how they are set up and configured, as well as the safety and decision support that they come with. So this masterclass is one of the many communication and engagement channels that they're exploring, and a focus group is currently being formed, which is due to meet in March to help guide this work. So if anyone is interested in being a part of this work, they should contact Michelle, the project manager. Her email is on screen on the slide. The numbers are limited, so if you are interested in being part of the work, then please do contact Michelle on there, and then you'll be able to get more details around this work and project. So we've had some great discussions today, and I hope you found the masterclass interesting. If there is anyone that would like to come and present on the EPMA masterclass, please do get in touch with Sarah. Her email will be on screen, and it's really great to hear from a variety of healthcare professionals to really get that multidisciplinary approach. So I do urge you to reach out to us, and we can let you know when there are opportunities in the diary to present. The questions that are remaining will be answered and shared on the Futures page, and the recording will be available after the webinar is finished, and you will also get emailed a certificate and a link to the recording, as well as the slides, which again are available on the NHS Futures page. The next masterclass is in March on the 26th, and again there's a link to register for that. So if you would like to join us again, it'd be great to see you all again. So please do register for that. And if anyone does have any other questions around the EPMA masterclasses, please do reach out to Sarah, and then we can answer these when they do come in. Once again, thank you for joining today's webinar, and we'll hopefully see you again in March. Have a great afternoon. It was great to see you all. Take care, everyone. Bye.